Okay guys, as we continue with our spinal anesthesia, so in this video I want us to talk about the choice of needle. The choice of needle is very important when you do a spinal, and the reason for that, you want a needle that will not, or that will increase the risk of there's something called PDPH, which is dural puncture headache. Guys, what's everything? Postural puncture headache. When you do a spinal or a lumbar puncture, the patient is at risk of developing a postural puncture headache. So one of the ways, we are going to talk about the complications of a spinal later on, but I have to talk about this now because it's related to the choice of needle that you use. So the needle that you want, you don't want a needle that has got a big tip, because when you've got a big tip, you leave a big hole. In the dura, and when you do that, CSF will leak in higher amounts and for longer when you leave a bigger hole, and that predisposes the patient to developing a postural puncture headache. So they are what they call cutting tip needles. First of all, the needles that are available are between 18 and 27 gauge. They are cutting tip needles, and then they are what they call pencil point needles. For me, I struggled to use a pencil point needle. Even when I was a student, when I was given a chance to do a spinal, I would struggle. Until recently, this other MO I was working with gave me confidence. So I hated pencil point needle. Even when I had a spinal, even in OPD, I would always run for the cutting tip. The cutting tip needle is the most common one. It's very common. It's just as thin as the other, but the difference, it's sharp at the end, and right there at the end it has got a hole. But the pencil point, they are really pencil point. They are really pencil point. The difference is that, yeah, they are smaller than that one, and also they are blunt at the end there, so they don't really pierce so much into the dura, and they've got their hole more on the side. This is the most preferred type of a needle. I mean, where I was training as a student in Kalafong, they always used pencil point needles, but they're not always available. That's why most of the times the cutting tip is used. Just know that with the cutting tip, since you're gonna open, you're gonna pierce, because it's cutting. The tip is cutting so sharp that you are gonna pierce into that dura. But this one, it just makes its way into the dura without really piercing it, so it closes sort of like immediately. This one leaves a hole that can start leaking CSF there. So that's the thing about it. Maybe I'll do a video, maybe 30 seconds video, where I'll show you the needles when I'm in the hospital, how these look. And this one is usually orange in color. This one is usually black, but yeah, we're gonna talk about that. So the difference between this, one of the difference between this, the reason why I struggled with this is because when you use this one, you need an introducer. So you need to use one of your small needles, like a green needle, to pierce the skin in those layers that I mentioned. And then after using this one, after having opened way, using the small needle, the short needle, the needle that we use for like injecting drugs, for withdrawing medication, that's the needle I'm talking about. So you're gonna push it in and leave it there, and then after that you use this pencil point and put it inside there. So use this one as an introducer. So you need an introducer for this one. So guys, this is something worth reading about, because they can give you a question and ask you the differences. Why do we go for this one and not that one? The size that we commonly use where I work with is a 22 gauge needle. So that's a choice of needle. So remember, there's a pencil point. So these are the safest, but the difference is that you cannot use them alone. You need an introducer, otherwise they cannot go through the skin. They will bend, they can even break, and all of that. Now let's talk about the choice of drugs. Like I said, we are gonna spend a lot of time on spinal anesthesia. Even if I do another topic, we are gonna come back and do spinal anesthesia, because it's the most common is that we're gonna do, especially when you go to the districts and all of that. So the drugs that can be used for spinal anesthesia, they include Bupivacaine, they include lidocaine, they include Bupivacaine, Bupivacaine, tetracaine. The list just goes on. But the most commonly used drug is Bupivacaine. So it's worth knowing everything about Bupivacaine. So Bupivacaine, as we all know, it's an amide in terms of local anesthetic classification, and it's broken down by, it's metabolized in the liver. And we also know that, so one of the reasons why it's chosen, it's because it's said to be very cheap, and it has got a prolonged duration compared with the others. And in terms of neurotoxicity, its effects are very minimal there. There are so many other reasons why they use Bupivacaine. So the issue of its effects being prolonged, it means that it also helps with post-op pain. If you give a drug that has got a reduced half-life, or its effects are not prolonged, it means that post-op you're gonna have to use a lot of drugs in controlling the pain, and it's believed to be around 4 hours to 6 hours. Then that's when your patient's gonna start having pain. So which means up to 6 hours post-op, you don't have to really worry much about using a lot of drugs to control the pain. But after 4 to 6 hours, then you can start increasing pain medication for your patient. So one of the reasons why Bupivacaine is chosen is because it's widely available. On top of it being cheap, it's widely available. Widely available. Okay, so I'm sure there are other reasons, guys, that maybe you can also look up. So let's talk about, let's zoom into Bupivacaine a bit. We're talking about the most commonly used local anesthetic for spinal anesthesia. It's Bupivacaine. Bupivacaine. It works in about 8 minutes. And it works for about 4 to 6 hours. Makes it ideal for long procedures and for post-op management. Bupivacaine comes in 2 forms as far as I know. There is a plain Bupivacaine, and then there's a heavy Bupivacaine. The heavy one is with dextrose. This one is without dextrose. So, why is that? The the marking that has got dextrose is added to increase its density. So the Bupivacaine that has got dextrose in it has got a higher density compared to the CSF. And the main idea there is that if you've got a container like that, the one that has got, let's say you've got CSF here and you've got marking here, the heavy marking. And you've got CSF there. What's going to happen is that because this one is heavier, gravity will pull it. So it's going to settle down there. And then the CSF will sort of like rise and be on top. This is what they call baricity. So this heavy marking is hyperbaric. Compared to the CSF. So this helps to limit, the level of the local anesthetic, which is in this case is bupivacaine, because you don't want that that local anesthetic to start working on the higher levels. Remember, we are going to talk about the complications of a spinal, like I said. You want this local anesthetic to work from L3, L4 down. You don't want it to start going up until it gets to dangerous levels like your T4 and your C8 level, where you get your high spinal and your total spinal. So the thing is, you want to prevent the anesthetic from working on higher levels, going up. When you do that, you are minimizing the chance. So using a hyperbaric local anesthetic sort of like minimizes and prevents things like high spinal or total spinal. So that's the thing about it. So whenever you use Marcaine or Bupivacaine, make sure that it's the one with dextrose. There are doctors who still mixes. The doctors, when they receive a Marcaine that is plain, when they receive a plain Marcaine, they know the ratio, or they can calculate how much Marcaine they can use, how much dextrose they can add to the Marcaine to make it to be hyperbaric. So using a plain Marcaine is dangerous, very dangerous. Okay, so these are very important things. They are very high yield that they can ask you to explain, especially for spinal anesthesia. I mean, for a spinal, we should know everything because it's the most type of anesthesia that is done by GPs like us. So that's the idea around that. So you can have local anesthetics that are isobaric. So when you've got an local anesthetic that is isobaric, there's no, wherever the CSF is, it's gonna be there. So that there is no differences in distribution. But when you've got a hypobaric one, it's the opposite of that. You want it to be hyperbaric. You want it to be heavy, like in terms of the density, right? So the doses for bupivacaine, they differ, they range between 6 and 15 milligrams. 6 to 15 milligrams for things like C-section, and 12.5 to 15 for other things. For other like lower limb surgery, perineal surgery, all those things. So I'm not sure if I'm forgetting anything. So in our next video, I want us to talk about the calculation of the Marcaine, because it's very important. The calculation and how much dose do we use. There's a standard dose that we use for C-sections that I will tell you about, because now you need to be able to know how much are you gonna draw in that 2 ml syringe, and also the dose, like the dose for C-section is standard. We're gonna talk about that. But when it's a C-section like lower limb ortho cases, the dose is usually higher, as you can see. It's usually higher. Okay, let's meet on another video, guys.